Hello, my dear students. Welcome you all to the Master Nursing classes. In this today's video, we are going to discuss the most important questions again on the ECG. So, as all of you know that we have discussed already part 1, part 2, part 3 of the ECG, where I have started with a very basic questions and I have left with some advanced questions. So, this is a continued part of the ECG where I am again discussing the most important questions here again. So here we will discuss the heart block, what's Mobitz type 1, Mobitz type 2, Wang-Beck phenomena, okay, and what is complete heart block, okay, when we have to use the atropine, when we have to go for the pacemaker. So what is the drug of choice in the children's in the bradycardia, what is the drug of choice in the adults in the bradycardia. So we will discuss those important points. Along with we will discuss the what is diagnostic criteria for the myocardial infarction by using the UCG, what is the ST elevated MI and what is the non-ST elevated MI. These are some expected questions and very hot questions. So we are going to discuss here. Not only these points, these are the headlines. Along with this, I am going to discuss the most important questions that may strikes in your exams as a very important topics. So without wasting time, we will start the today's class. Before going to the main class, here is a beautiful motivational quote for you all. Before anything else, preparation is the key to success. What it means, bachcho? You people are thinking that I have prepared half and my syllabus is still not covered and exam is only 20 days. Bachcho, believe me, you have read everything, you have practiced everything, and just one revision is required and it's possible from your side. If you are really aspirants and really struggling to get the exams to get cracked, so you have to do it. There is no any alternative way for the hard work. Remember, hard work always wins on the intelligence. If intelligence won't works, it will go into the failure zone. If hard work works, it will go into the peak of the success. So believe in yourself. First, you have to say, I can do this one. It is possible from my side because I am working and I am preparing. But you believe me, if you are preparing perfectly, and no one can stop you to get success, right? So before anything else, preparation is key to success. And if you are preparing, so no one can stop you to get success. So if you are believing on yourself, if you are having the positive vibes around surrounds of you, so that may create a positive, definitely that will create a positive results. And you people are practicing a better, a best quality test series from the master nursing classes. And from our side, what we have given, not like we have lifted question from this one, that one, and we have thrown, not like that. Completely we have planned the syllabus since from your day one of the test series till here. Believe me, no question will arise out of our box because we have covered the whole syllabus, right? So practice that one very nicely, revise the important questions again, okay, and make a note of the points where we are mentioning that it's important in the test series. That is going to be very much helpful for you all. If you are not a part of our test series and app, so the link I have given in the description box, you can download from there also and you can enroll. Now also the time is there, and now also we are giving a very important questions, right? So yes, can we start the today's class, bacho? I will give the link in the description box. And if you are want any guidance and preparations related NARSET 8, 9, and 10, 11, so we have the beautiful groups where we will share everything related to the recruitments. So that is also the WhatsApp group and channel and Telegram group and channel. We will give the description link in the description box. If you want, you can join there. Okay. So and if you are first time watching our Master Nursing Classes channel, so please do subscribe to the channel. And after explaining the first question, if you found the content is powerful without wasting any time, so please hit the like button. Okay, so let me explain the first question for you all, right? So here is the first question. Do read the question, that's very important for you all. Okay, make a 5-star on in front of this question, right? So which of the following ECG finding is most characteristics of the STEMI? What is the full form of the STEMI? So it indicates, yes, ST segment elevated myocardial infarction. Okay, so it indicates the ST segment elevated myocardial infarction. So what is the ECG finding as a characteristic feature we have to see in the ST elevated MI? So, bachon, as all of you know that we are having the two types of the myocardial infarction. One is the ST elevated MI and another one is the non-ST elevated MI. Okay, so one is the ST elevated MI and another one is the non-ST elevated MI. So, what is the difference between this one? Let me explain. So, there is a very basic concept before going to the difference. You have to know that. So, we are having a beautiful vessel. We call that one as in the coronary artery. Okay, this is the beautiful heart, and from here the aorta arises, and from here the coronary arteries will arise. So, these coronary artery which supply oxygenated blood to our heart, right? So when this coronary artery 70 percentage get blocks, how many percentage? If it's get blocked 70 percentage, means there is symptoms of the myocardial infarction. Okay, so there is muscles called as the myocardial muscles, the contractile muscles of the heart. If it's getting the lack of oxygen and blood, so it will get infarct. It will get necrosis. So that is what we call as the myocardial infarction. Okay. So, sir, this is the basic we understood, sir. What is the difference between the ST elevated and non-ST elevated MI, sir? Yes. Let me clear that one. Consider this one a myocardial muscle, right? With this much thickness. Okay, this much thickness, the thickest part of the heart also the myocardium. Okay, so this is the myocardial muscle, and here also this is the myocardial muscle. Okay, this is the coronary artery which is supplying to the myocardial muscle, and this is the coronary artery which is supplying to the myocardial muscle. When this coronary artery completely blocks, at this particular time, it is unable to supply a single 1% also oxygen and blood. So the transmural means complete length of the muscle and complete thickness of the muscles, it will get necrosis. At that point of the time, the potassium which will comes out of the cells. As all of you know that this is the cell. Inside the cell, the abundant ion is the potassium. Okay, if the cell is damaging and necrosing, this potassium it will comes out of the cell, and there is increased potassium around the heart, so which elevates the T wave. So tall T wave we can see with the yes hyperkalemia. Along with that, we can see the tall T wave as the earliest manifestation of the myocardial MI. Okay, so this is the ST segment elevated MI. Here the T wave will increases means the ST segment also increases. Okay, this is the normal ECG. All of you know that. This is the normal ECG. Here the P wave, Q wave, R wave, S wave, and this is the T wave. Okay, T wave is highlighting increasing means the ST segment also it will get increases like this. So the tall T wave and ST segment elevation is the hyperacute T wave, and ST segment elevation indicates the earliest ECG changes of the MI. So this happens when only completely heart muscles will get means the transmural means complete thickness of the our myocardial muscles is getting infarction here. And this side, this artery is partially obstructed. This coronary artery is not completely obstructed. This side it's completely obstructed. This one the partial obstruction. And here the not complete length of the muscles will get necrosis. Only this half of the muscles will get necrosis, and another half of the muscles will remain unaffected. Okay, no, there is no transmural necrosis. It's only a half partial necrosis of the muscle will be there. So at this time there is failure to elevation of the ST segment. So this is what we call non-ST. This is what we call non-ST segment elevated myocardial infarction. So this is the very basic thing all you people have to understand, right? So to diagnose the ST elevated MI, so there is diagnostic criteria. Yes, some of you have already chosen the correct answer. Okay, that is the option B, ST segment elevation in the two or more contagious leads. Okay, so in two or more contagious or continuous lead, if the ST segment is elevated, So this is the classical indicates the ST elevated MI. Okay. So let me go for the next question. And as I told, if there is a quality in the content in the after explaining the first question, if you people found means I told you to like, right? So I'm waiting now for a 3 second. So please everyone like to the session. If you found it's helpful, please do like to the session, right? So all of you, I think there is clarity related to the ST segment and non-ST segment elevated MI, right? Okay, very nice of you all. Thank you so much for your beautiful response, right? So we'll start the next question here. Okay, that is again on the non-ST elevated MI. Just now only we have discussed it. Now just the learned and acquired knowledge need to apply, then only the rank will come. So just now only you people have learned here, okay, you have gained the knowledge here, just now try to apply that knowledge here. Okay, so yes, which ECG finding is characteristics of non-ST elevation myocardial infarction? Okay, yes, option A, deep Q waves in the multiple leads. It's unrelated to the question, I am eliminating. And option C, ST segment elevation in the lead second, third, and augment vector foot. So this indicating inferior wall MI. Okay, what it indicating? It indicating inferior wall MI. Okay, so already we have discussed in the second class. Okay, the location and the leads of the MI. Okay, we have discussed already this one, right? So this is unrelated to the question. I will eliminate this one, right? So the option D goes to the prolonged PR interval. So if PR interval is getting prolonged, which indicates the AV block, or we can say simply heart block. So we will discuss in the heart block. Okay, it will come next. So I'm eliminating the option D also here, right? So the correct answer, and almost all of you people have choose that ST segment depression will be there. Okay, ST segment will go inversely, and TVA will also it will go inversely. Okay, so there is the ECG will be normal ECG will be like this, right? And here the ST segment will get inverse and like this, and T wave also get inverse like this. Okay, so this is what we call as the non-ST elevated MI. It's clear, I think so, right? So the next and beautiful and very important question. So make a 5-star on this one, right? So after that we will discuss the image based question also. I will give a complete clarity. You people never ever miss that question, and after attending that question in your exams, you people really feel proud about the master nursing classes, because with the theory and basic concept, I am building your concept, but no one can stop you from your selection, right? Yes. Here is the next question: an abnormally large U wave. So we can say the prominent U wave may indicate which of the following? What it indicates? Option A, hypokalemia. Option B, hypercalcemia. Option C, hyperkalemia. And option D, myocardial infarction. Yes, but it indicates myocardial infarction also. But here we are having the another option also in the options, that is the hypokalemia. In the hypokalemia, classically there is prominent U wave will be there. Okay, so if both are in the option, the first option and answer goes to the hypokalemia, then the second answer goes to the myocardial infarction. Okay, so what are the ECG changes which happens in the hypokalemia? Okay, what is hypokalemia? Normal potassium level is the 3.5 to 5.1 okay milliequivalent per deciliter. This is the normal potassium level, right? If it is coming less than 3.5, so we can say this one as in the hypokalemia. If potassium is get decreased, yes, as I told, the T wave also get decreased. Means T wave inversion will be there. ST segment depression will be there. Okay. Then along with this, classically we will say prominent U wave. Prominent U wave. So in the last class, I have discussed the ECG changes in the hyper and hypokalemia buncho. Here it is, right? So ECG changes, as I told, it's very, very important. Again, I am revising here because it's important. In hypokalemia, inverted T wave will be there. ST segment depression will be there. And U wave prominent will be there. Already discussed the theory part, and there will be people have faced MCQ. That's it. Here also same. We are building the concept, and cracking the MCQ and getting the ranks. That's it. Okay. So here are the ECG changes in the hyperkalemia. Increased potassium more than yes 5.1. So potassium increases, height of the T wave increases. Potassium decreases, height of the T wave decreases. Okay. So T wave tall, ST segment elevated, P start to disappear, and uh, PR interval get prolongs. Okay. So it's very, very important for you all. Again, I am making 5 star on this one, which it helps to you in the exams. Okay. So do revise that one. Yes. So here's the answer for our questions. So that is the hypokalemia. We used to see the large U wave. Okay. Then here is the next question. A prominent J wave may be associated with which of the following condition? So prominent J wave. First, know what is the J point and what is the J wave. So let me clear. This is the P wave. This is the QRS complex. Okay, and this is the T wave. Focus here. Is it looking like J? This part, is it looking like J? Right? So this particular point we call as in the J point. J point is completely normal. It's completely normal. J point is completely normal. Okay, in all ECG. If I take my ECG also, I will get this one. If I take your ECG also, I will get this one. But what is J waves are? J wave means when this J points, it will get prominent like this. This is the P wave. Here you are getting like this. Okay, so the prominence, it's going like this. This is what you call as the J point. So the J point, sorry, this is what we call as the J wave. Okay, so J wave is abnormal. J point is normal. Okay, J wave is abnormal. So this J wave we also called as in the Osborn wave. What we can say this one? This is also called as the Osborn wave. So this J wave or Osborn wave in the ECG, it clearly indicates the hypothermia, which clearly indicates the hypothermia. Bacho, it's important. It's important for you all. Okay. So here is the next question. So do read the question perfectly, properly, and fadafat, and try to give your answer in the comment box. Right. Yes, I am telling repeatedly, if anyone is new to the session, so please do like to the session. And if you are new to the master nursing classes, please take a subscriptions. It's a free. Just you have to click over the subscribe button and be a part of our master nursing classes and have a great knowledge. Right? Here is the next question. Which of the following is not characteristics of the first degree heart block on ECG? Okay. So the question is not a characteristics of the first degree heart block. So let me clear what is the heart block first. Okay. So as all of you know that this is our beautiful heart and this is the yes our right atrium, left atrium, right ventricle, left ventricle, right? So here is the superior vena cava, here is the inferior vena cava. Just below the superior vena cava, or we can say this is the cava, this is the atrium. Okay, between the just between the cavo atrial junction, or we can say just below the superior vena cava, we are having the node that is what we call as the sinoatrial node. From here, the conduction starts. Means the impulses, electrical activity starts from here. Okay, so it will supply to the left atrium, it will supply to the right atrium. Okay, completely, and it will send the signals to the our AV node. Okay, so this is what we call as the AV node. This is what we call AV node. So AV node location is just above the tricuspid wall in the right atrium only. Okay, in the right atrium only, just above the tricuspid wall, it will be located here. Right. So it's important. So the impulse starts from here and it will goes to the next node, that's the AV node. From here to the our bundle of H. Okay, and from the right bundle branch, left bundle branch, and to the Purkinje fibers. Okay, to the Purkinje fibers like this. This is what we call the conduction system. If is any sudden blockage, if any sudden blockage in the conduction system. So we call this one as the heart block. We call this one as the heart block. Okay. So if it's an blockage at the level of the SA node to the AV node, so that is what we call as the AV node block. That is what we call the AV node block. So based on this one, so we are having the heart block. That is, first I will classify and clarify. So then we will go for the main important thing. That is the heart block. Okay. Heart block. So here we are having the three types of the heart block, right? First one is the first degree heart block. Second one is the second degree heart block. Third one is the third degree heart block, right? So in second degree, again we are having two types of the heart block. One is, yes, Mobitz type 1, and second one is the Mobitz type 2, right? So these Mobitz type 1 we also call as the wings back phenomena. What we call this one is we call this is also as a wings back phenomena. Okay, we'll discuss just in the next slide only. Incomplete, we will discuss what is the first degree heart block, what is the second degree heart block, what is the Mobitz type 1 and wings back phenomena, what is the Mobitz type 2, okay, and what is the third degree heart block. So we'll discuss in detail. Just I have classified here. Okay, so then comes to the main thing, right? So this is the question. So which of the following is not a characteristics of the first degree heart block? Okay, so here the question asked not characteristics. Okay, so what happened actually in the first degree heart block? Due to the blockage in the conduction, there is prolonged PR interval. Okay, so let me comes to the what is normal PR interval? What is the normal PR interval? Look at this one. The PR interval starts with the beginning of the P wave and at the end of the our Q wave. Okay, this is what we call the PR interval. If this interval, it should be formed between the 3 to 5 small box, or we can say 5 small box means 1 large box, right? So all of people know one small box is containing having the duration of the 0.04 seconds. Means here the one small box is 0.04 second, means the 5 small box means it should be 0.20 second. If in case 3 small box means that would be 0.12 second. So the normal duration of the PR interval is 0.12 to 0.20 seconds, right? So this is the, we can't say 0 here, we can say the 0.2 second also, that is the normal only. Okay, so it's important. If in case the PR interval is going more than 0.2 second, we call this one as the prolonged PR interval. So what we can say this one? We can say this one is the prolonged PR interval. So look at this images, Kocho. So as I told, it will start with the beginning of the P wave to the here, right? So count down the small box 1, 2, 3, 4, 5, 6, 7, 8 small box it took. Okay, 8 small box means yes, it's going more than, yes, make 0.04 into 8, right? Your result will be okay more than 0.2 seconds. Okay, so that indicates it's a prolonged PR interval. Okay, and it's constant. Here, look, this is 0. Consider 0.4 second, and this is also 0.4 second. This is also 0.4 second. So constantly prolonged pair interval, but there is no any drop bit. Okay, so here after P wave, the QRS is there normally. After P wave, again the QRS is there, means there is no any drop bits here. Just the PR interval is get prolonged here, and PR interval duration is got more than 0.2 second. So this is what we call as the first degree heart block, bacho. In the first degree heart block, there is no any drop bits. Okay, there is no any drop beats, means the rhythm will be regular here. Okay, after PVO the QRS complex comes normally, that is means the rhythm is normal here. Okay, there is no any drop beats in the first degree heart block. Okay, so let me comes to the question here. Okay, the not a characteristics, right? So option A, the prolonged PR interval. Yes, the PR interval is prolonged and the PR interval is greater than 0.2 second. Okay, the PR interval is greater than 0.2 second, then only I used to say the PR interval is prolonged, right? And the rhythm is normal. Okay, the regular rhythm means every after P wave the QRS complex is coming. Okay, so the rhythm is normal. And option D telling a dropped QRS complex. In the first degree heart block, there is no dropped QRS complex. Okay, so the answer for this question goes to option D, that is the dropped QRS complex, which is not a characteristics of which is not a characteristics of our first degree heart block. I hope it's clear for you all, right? In question they have asked not characteristics, means the drops bit will not seen here, so it's not characteristics. So I'm putting the answer this one, right? So the correct answer here as our option D, a drop bit of the QRS complex, it will be not seen in the first degree heart block. So let me go for the next one. Yes, here. The question is here in front of you. So which of the following is a hallmark sign of the second degree heart block? So what is the hallmark sign? Hallmark sign or the classical sign means it will be clearly indicating that this sign will be a particular disease condition. It indicating the particular disease condition means it's a specific, we can say. Okay, so the hallmark sign of the second degree heart block, or you can say type 2, sorry, second degree heart block type 1. Okay, as I told here, in the second degree heart block we are having the Mobitz type 1 or the second degree heart block type 1, and second degree heart block type 2 or the Mobitz type 2, right? Here the question is related to the second degree heart block type 1 regarding this one, right? Yes, which of the following is the hallmark of the second degree heart block type 1? That is the Mobitz type 1, which is also called as Wench-Bach phenomena. Bacho, this will be your RRB question. Okay, so the Mobitz type 1 is also called as the Wench-Bach phenomena, right? So what is the hallmark and classical sign of the second degree heart block type 1 or the Mobitz type 1 or the one? So, yes, please do answer here. If any voice issue, I will fix it. Don't worry about that one. Okay. So keep a standard quality in your YouTube, so it will come clear to you. Okay. So option A is a fixed PR interval. Option B indicating progressive PR interval prolongation followed by a dropped beat. Option C is the QRS complex is widening. Option D dropped P waves without PR changes. So let me clear what is the second degree heart block type 1 or the Mobitz type 1. Okay, so here will be your ECG. Bacho, in the Mobitz type 1, there is prolonged and progressive increase in the PR interval. So what it means? What's the progressive increase in the PR interval? Okay, so look at this PR interval. So this would be a 0.3 second, means the next PR interval will be 0.4 and this one will be 0.5. Then the drop beats will come. Okay, here will be the drop beats. So the gradually prolongation of the PR interval until the drop beats come is a classical sign of the Mobitz type 1, or we can say the Wench-Bach phenomenon. What happens here? The PR interval is gradually increasing. In the first wave, it's a 0.3. In second wave, it's a 0.4. In the third wave, it's 0.5. Means the gradually, as the waves goes, the duration is gradually increasing until the drop beats comes. Right? So this is what we call as Mobitz type 1. Okay, this is what we call the Mobitz type 1, or we can say, yes, the Wench-Bach phenomenon. So here also they have written clear the PR interval gradually elongates until a P wave is completely blocked and the drop beats will come. Okay, this is indicating the Mobitz type 1. So here in the Mobitz type 2, the PR interval is elongated, means increasing. It's 0.3 means the second one also 0.3, third one also 0.3. Sir, this one you told in the first degree heart block, sir. Again you are telling here. Pacho, I will tell the difference. You people don't have to worry. Just believe on your master. I am giving here a blaster questions with the complete differentiation and clarity. Okay, so this is also 0.3 here, right? Constantly there is constant, not progressively increasing. It's a constantly progressive P wave, right? Sorry, PR interval plus a very frequent drop beat. Okay, after one P wave, here is the QRS. Again, next after P wave, there is no QRS complex. Next again P wave comes, there is no QRS complex. Again P wave comes, there QRS complex will be there. The main differentiating is very frequently there will be an absent of the QRS complex. I am not telling complete absent of the QRS complex. I am telling very frequently there is drops between the in the QRS complex. So this is what we call as the Mobitz type 2. The pair intervals are constant. The pair intervals are the constant, constantly increased. Okay, 0.3, 0.3, 0.3, constant. And the P wave not conducts here completely. So P wave not conducting completely means the P wave only generates and QRS complex will not generate. And the specific questions comes here like the ratio between P wave and QRS complex. But you look at this image here. Here is a P wave, P wave, P wave, and only one QRS complex is here. So the ratio here comes as 3 is to 1, or we can say 2 is to 1 also. In normal rhythm, what happening? Every P wave there is QRS complex, right? In the normal rhythm, every P wave after that QRS complex will be there. But here the very frequently the QRS complex is getting absent, so that is what we call as the Mobitz type 2. Okay, so it's very important, and this P is to QRS ratio 3 is to 1 or 2 is to 1. It's your classical questions that may strikes in your exams, right? So the next question, just now only I have explained the theory completely. You have grabbed the knowledge perfectly. Just apply it here and make me happy, bachu. Right? Just apply it here and make me happy. I'm waiting for your response here. Yes. So try to give a response. So which of the following characteristic feature of the Mobitz type 2, or we can say the second degree heart block type 2? Okay. So we have just described second degree heart block type 1 and type 2 in detail. So that only knowledge people have to apply here. Option A is the progressive lengthening of the PR interval. No, bacho. Here in the second degree heart block type 2, Mobitz type 2, there is no progressive. It's constant. It's constant. So I'm eliminating option A. So then comes to the option B, a constant PR interval with a frequent drop QRS complex. So this is what classically the hallmarkly we have explained as the classical symptom of our second degree heart block type 2 or the Mobitz type 2, the constant PR interval with a very frequent absent of the QRS complex where the P is to QRS ratio would be 3 is to 1, or we can say 2 is to 1. Okay, so this is what we have discussed just now back in the last slide. Okay, so here's the next question for you all. In the third degree heart block, which of the following occurs? So for the third degree heart blocks, for a third degree heart blocks, we are also called as the complete heart block. We are also called as complete heart block. The heart is completely blocked here in the third degree heart block. So what happens here? What is happening here? As I told, the conduction system from the SN into AV node to Purkinje bundle of his, from there to the right bundle, left bundle, and Purkinje fiber. So here the impulse generated, but it's not completely transmitted and it's completely get blocked. From the SA node impulse generated and it came to the AV node and the PO generated. After that, it's completely blocked. Means it is not conducting to the our bundle of his. Means the signals is not going till the ventricles. So the answer here, the POs are not conducted to ventricles. Means here will be the complete blockage will be there. So this is what we call the P wave not conducted to the our ventricles. So there is only P wave will be there, and here this will be the ECG. How will be the ECG? Let me draw and tell you. This is P wave, no QRS complex. Again P wave, no QRS complex. Again P wave, no QRS complex. Means complete absent of the QRS complex. Okay, so that is what we call as the third degree heart block or complete heart block. So here in the first degree heart block and second degree heart block, okay, so the treatment I will tell now. So it will give a clarity to you people, right? So please wait just a second to go for the back slide. Yes. So in the first degree heart block, so it will causes the bradycardia. Yes, of course, it will causes the bradycardia because there is no conduction of the heart means there is bradycardia. Okay, there is bradycardia, right? Bradycardia means heart rate will get decreases. So if heart rate is getting decreased, okay, less than 60, and there is no symptoms means we call that one as in the asymptomatic bradycardia. There is no any treatment required in the asymptomatic bradycardia. But if in case, if the heart rate is less than 60, whatever it may be, if it may be a 50, 40, 30, 20, and 10, but with symptoms, we have to treat there. So with symptoms means what are the symptoms? The symptoms of the breathlessness, the symptoms of the apprehension, and the cells are craves for the oxygen. There will be a cyanosis will be there. If the symptoms of the hypoxia generates, so we have to treat the bradycardia. So with the drug of choice in the adult for treating the bradycardia, many times we have discussed this one, bacho. I don't know how many times I have told you the drug of choice for bradycardia in the adults. That is the atropine. Okay, so let me clear again with the dose because it's important. Because it's important. Bacho, in the bradycardia, if positive symptoms, positive sign and symptoms, where we have to start the drug of choice first. So that is what in the adult atropine sulfate. In the children's drug of choice, in the children's, that is adrenaline, or we can say epinephrine, right? So it's clear, very important. The examiner will not stop here only. He will ask the dose of the atropine. Yes, sir. Can we have to remember every drug dose? No. Few drug dose, whatever it is, that one you have to remember. Bacho, remember the old concept, then you will go for the new concept. Then I will teach you which one you have to choose. Okay. So please wait just a second. So this is the old concept and this one is the new concept, right? On the treatment of the bradycardia. So previously, in the treatment of the bradycardia, previously also atropine only the drug of choice, right? So there we used to give 0.5 mg, maximum 6 dose, that is the maximum 3 mg. This is the old concept. The new concept is atropine in adult bradycardia, that is 1 mg, maximum 3 dose, total is 3 mg. Total is 3 mg. If this question comes in your mark sheet, use this one only, read this one only, apply this one only, and in your few books, still this concept is there, delete this one. Okay, and use this one. Okay, so now the dose of atropine in the bradycardia is the 1 mg, maximum doses 3 doses. Okay, total 3 mg we have to give. Okay, this is the important, very important question for you all, right? So it will helpful. So in the first degree heart block, right? So we use as a atropine as a drug of choice. And in the second degree heart block, the first drug also atropine we have to use. If it's not responding, we used to go for a transcutaneous pacemaker. Transcutaneous pacemaker means we will not implant anything inside. Transcutaneous means through the cutaneous. What is the cutaneous? It's not cutaneous, it's an cutaneous. Means through the skin we have to go here. Okay, on the skin we have to keep the electrode and we have to generate the impulse externally only. Okay, so the transcutaneous pacemaker would be used in the Mobitz Type 1 as second, and in the Mobitz Type 2 also we can use if the bradycardia is not responding to the atropine, we have to go for the pacemakers. And in the third degree heart block, we have to go for the permanent pacemakers. Permanent pacemakers, we have to go in the third degree heart block. So here, first priority is the atropine, then second one is the pacemaker, that is the transcutaneous pacemakers. So is that clear, Bachu? Yes, it's clear because it's very easy. That's what it's clear. That's simple. Okay. So let me go for the next one here. Okay. So we have explained this one. Very important and easy. We have explained this one. Okay. So here is the next question. So which of the following electrolyte disturbances can lead to the prolonged QT interval? Bacho, make an 100-star question for this. It's important. Which of the following electrolyte disturbance can lead to the prolonged QT interval? Remember, if the QT is prolonged, means the calcium will get decreases. So QT increases, that means the calcium decreases. Means the QT interval is inversely proportional to the our calcium. So if in case the short QT means the calcium will increase. Short QT seen in the hypercalcemia and prolonged QT seen in the hypocalcemia. So our answer here, the option D, hypocalcemia. Remember this one. The QT is inversely proportional to the calcium. If QT is prolonged, the calcium is low. If QT is short, the calcium is high. Okay, so this is the inversely proportional. Okay, so we can say inversely proportional means directionally proportional means if one thing increases, the same opposite thing also increases. So that is directly having a direct relationship. There is no opposite relationship. If there is opposite relationship, this one is increasing means this one is decreasing. So this is what we call as the inversely proportional. Okay, so the QT is inversely proportional to the calcium. The QT is getting prolonged means the calcium is getting decreased. The QT is getting short means the calcium is increasing. So this is the relationship. Remember, apply and get the rank. That's it. Okay. If you want why it happens, how it happens, it is a very lengthy things I can explain, but now we don't have the time. Just I'm covering the important points and think with a clear concept that is necessary and how much necessary for you people. I know it's why it happens, how it happens. It takes a little bit 7 to 8 minutes extra to explain, but so we have to save the time and revise the important thing only. So that is the thing I am doing here, right? So I am not here to here to tell how much knowledge I am having. Just I am here to boost you people because it's the last minute time and I want to improve your marks. That is the reason. So I am keep on revising the important thing and keep on pushing you the important thing only. Okay, so that is the focus in these classes, right? So the next question is when when is the transcutaneous pacemaker most commonly indicated in the management of the bradycardia? So just now only we have told when we have to use the transcutaneous pacemaker, first we have to use the atropine sulfate as a drug of choice. If still, if still the drug is not responding, means the heart rate is not improving for the medication, means then we go for the our pacemakers. Okay, so that is the very important and search the option here. In case of the symptomatic sinus bradycardia with heart rate of the 50 beats per minute, so it's symptomatic and heart rate is 50 beats per minute. So first go for the atropine. First go for the atropine, then go for the pacemaker. If its atropine is not useful, then go for the pacemaker. Okay, so option A is not our answer here, right? Option B, when atropine is ineffective in resolving the symptoms of the bradycardia. Yes. So if we are giving the atropine and it is not giving any effect, it's ineffective to resolve the symptoms of the bradycardia. So this point of the time where we have to use the or pacemaker. Okay. So in case of the first degree heart block, yes, first degree heart attack, first is the atropine, then it's not useful, then for the pacemaker. Okay, in for the non-cardiac cause of the bradycardia, such as hypothyroidism. So here, treat the cause, treat the hypothyroidism, it increases the heart rate. Okay, so there is no need or no need of the pacemaker, right? So our answer here is the option B is the correct answer, right? So I hope it's clear for everyone. I think it's clear for you all, right? So here is the next question. Yes, very important, very beautiful question. So fatapat, give response to this question. We will move on. Which of the following is the first line treatment for the patient with Torsades de Pointes? So we can also call this Torsades de Pointes as an polymorphic ventricular tachycardia. Okay, so we call Torsades de Pointes also as in the polymorphic ventricular tachycardia. Means here the problem is in the ventricles. Means we have to search the problem in the QRS complex, right? And this is poly means more than one. So it may be two, it may be three. Morphic means morphology means characteristics. Okay, so here we are having more than three type of the QRS complex with widened QRS complex, and there we are getting the more than three types of the QRS complex wave. So that is what we call as the polymorphic ventricular tachycardia or Torsades de Pointes. Okay. So here the question is which of the following is the first line treatment in the patient with the Torsades de Pointes? First line treatment is the yes. Option A magnesium sulfate. Option B amiodarone. Option C electrical cardioversion. Option D lidocaine. So first and best and the drug of choice for the Torsades de Pointes is the IV magnesium sulfate. Yes, this magnesium sulfate is the same thing where we are using in the treatment of the eclampsia and severe preeclampsia. Okay, so that magnesium sulfate only. Here we are giving the intravenously IV magnesium sulfate is the drug of choice for the our Torsades de Pointes. But it's important. The drug of choice for the Torsades de Pointes is the IV magnesium sulfate. It's important, right? Yes, is that clear? So let me clear what is the Torsades de Pointes. Okay, what is the ventricular fibrillation? What is the ventricular tachycardia? What is the this one? What we call polymorphic ventricular tachycardia in detail. So as I told, these are the ventricular tachycardia. Okay, look at this one. Ventricular tachycardia, polymorphic ventricular tachycardia or the Torsades de Pointes, ventricular fibrillation. Means the problem is there in the ventricles. As well as you know the basic This is the P wave. This is the QRS complex and this is the T wave. This P wave happens because of the atrial contraction or the contraction of the atrium or atrial depolarization, we can say. And this QRS complex happens because of the ventricular contraction or ventricular depolarization, we can say, or ventricular systole also, right? And this T wave generates because of the ventricular, yes, relaxation, or we can say ventricular repolarization, right? So here the ventricular tachycardia is there, the polymorphic ventricular tachycardia is there, ventricular fibrillation is there. Means the problem is there with the QRS complex. Okay, the problem is there with the QRS complex. So main focus while assessing the ECG is our QRS complex here, right? So I hope it's clear. When you see the QRS complex, if it's wide, there is wide QRS complex. Means the normal QRS complex should be generated within the 2 to 3 small box. And the normal duration of this QRS complex or the QRS interval is 0.08 to the 0.12 second. Okay, this is the normal duration of the QRS complex. We have discussed in the video 1, video 2 also, right? So this is the normal duration. If it's going more than 3 small boxes, or if it's going more than 0.12 seconds, so that is what we call the wide QRS complex. If the QRS complex is wide, so then we have to look at the RR interval. Okay, so then we have to look for the RR interval. Means consider this is the ECG. Okay, T wave, then P wave, QRS complex, T wave. Okay, so just a second, please. P QRS T, P QRS, then T. Okay, then again P QRS, then T. So this is called as the RR interval. Okay, so here consider this is between the 4 large box. Okay, so this is between the 4 large box. So this interval is between the 4 large box. This is between the 4 large box. So this is what we call as the regular RR interval. We call this one as the regular RR interval. Okay, consider this RR interval. Okay, this is the difference is the 5 large box and here the 3 large box. Means between the two RR intervals, the large box was different. So we call this one is the irregular. Okay, we call this one is the irregular RR interval. Okay, so first what we have to see here, we have to look at QRS complex. If it's wide, so then we have to look at the RR interval. Okay, so if RR interval is regular, means that is what we call as the ventricular tachycardia. If RR interval are irregular, then again we have to look at whether the 3 different type of the QRS complexes are there. Yes, if 3 different complex type of the QRS complexes are there, that is what we call as the polymorphic ventricular tachycardia or the Torsades de Pointes, right? If the QRS complex is unable to differentiate, okay, whether it is a normal, abnormal, we are unable to differentiate, okay. So like this, it will be there, nothing like we are unable to differentiate. So that is what we call as the ventricular fibrillation. So this is the basic all people have to understand, right? If in case the QRS complex is narrow, make a note of this one, practice this one 3 times. It will definitely comes to you and it will definitely helps to you to identify the image, whether it is the PSVT or whether it is a atrial fibrillation, atrial tachycardia, what maybe you can identify easily image, because immediately after this one I will show the image and I will clarify all these things with image, so it will be very much it will fit in your mind very nicely. Okay, so yes, if the QRS complex is narrow, means the problem is there with the atrium. How, sir? How means the atrium is generating impulses very fast, so QRS becomes synchronized with the atrium and it will also generating the impulses very fast. Okay, so because of that, the QRS complex is narrow, means mostly the problem will be in the atrium. So let me comes to this one. Okay, so if the QRS is complex narrow, okay, so then again we have to look for the R interval. If R interval is regular, So that is the PSVT. If R interval is irregular, so that we have to look for the again three different type of the P wave. If three different type of the P wave, that is what you call the multifocal atrial tachycardia. If P waves are undifferentiated, that is what you call as the atrial fibrillation. Okay, so let me clarify this one with the images. Okay, look at this image, bacho. First, what we have to see whether the QRS complex is wide or narrow. Okay, look at this image and identify whether the QRS complex. This is the Q R S. Okay, so whether this QRS again Q R S. Bacho, I told this QRS complex should be generated within the 2 to 3 small box, or its duration should be 0.08 to the 0.12 seconds. So this is the normal duration and normal length of the QRS complex. Right? Count it here. Yes, if this image is not clear, I will show another image. Don't worry. Okay. So don't worry. Just if it's clear to you, just watch on this one. Okay. Count the small box. 1, 2, 3, 4, 5. So here are the 5 small boxes are there. Okay. So again, count here. It's 5 small box. Here also count here the 5 small box. Means the QRS complex is here. It's wide QRS complex. Right. It's a wide QRS complex. So then check for the RR interval. Whether it is regular, okay, check for between this one. No, it's irregular RR interval. So QRS complex is wide, and RR interval are irregular. So it may be a ventricular fibrillation or it may be ventricular polymorphic ventricular tachycardia. So for we can say that it's a polymorphic ventricular tachycardia of the Torsades de Pointes. There should be more than 3 types of the QRS complexes. Look at this one. This is the another set of the QRS complex. Again, here will be there another set, and here will be the another set. 1, 2, 3 types. More than 3 types of the different types of the QRS complex we are getting here. So this is the image based question for the Torsades de Pointes. This is the image based questions for the Torsades de Pointes. Sir, then how the ventricular fibrillation and ventricular tachycardia looks like, sir? Yes, I will tell. Don't worry about this one. Look at this one. This is what we call monomorphic ventricular tachycardia, or just we can say it's a ventricular tachycardia. Right? So what happened here? Check the QRS complex. This is the QRS. Again, the QRS. So here, the between these QRS 1, 2, 3, 4, 5, 6. So 6 small box will be there. Means the QRS complexes again, the QRS complexes is wide here. Okay. Then check for the R interval. Bacho, look from starts to end. The difference between the two R interval is same. So QRS is wide and R interval is yes regular. So we can say this one is the ventricular tachycardia. Very simple. Comes to our flow chart. Yes, QRS is wide and R interval is regular. There is one thing, that's the ventricular tachycardia. So this is the classically the graphical representation of the ventricular tachycardia. It's very important, and make a 10 star question on this one, bacho. After exams, I will come with the screenshot from this one. There is the highest chance of the asking the question because it's asked many times in the exam. This is the ventricular tachycardia image. Sir, what is this, sir? Same again. Okay, count the QRS complex. Yes, it's wide QRS complex. Then again R interval regular. QRS complex is wide and R interval is regular. Again, it's in ventricular tachycardia. Same images. First, second. Okay, so comes to this image. Count the R interval. Sorry, QRS complex first. Q R S. So here the 1, 2, 3, 4, 5, 6. Again 7. Okay. There are 7 small boxes. Normally it should be generated between the 2 to 3 small boxes. Here it's generating between the 7 small boxes. Means our QRS complex is wide here again. And we are unable to recognize. Okay, we are unable to recognize. Okay, here is the different one. This one is different one. This one is different one. This one is different one. This is the different one. This is the different one. Means we are unable to recognize here. We are unable to recognize. So this is what we call as the QRS complex is wide, QRS complex is wide, and the RR interval is irregular. Yes, the RR. Can you able to identify RR interval or regular? Please wait. Yes, the QRS complex is wide. The RR interval is the irregular, and the waves we are unable to recognize. Apply the same thing here in our chart. In our chart here. So the QRS complex is wide, the RR interval are irregular, and QRS are unable to recognize. So it's a ventricular fibrillation. So we can say it's an clearly the ventricular fibrillation image based question. The 1,000 point important question. Okay. So the 1,000 point important question, ventricular fibrillation image based question. It will definitely strikes in the exam repeatedly. Okay. So then we have to come for the second thing, that is the narrow QRS complex. As I told the theory already, it's a narrow QRS complex means again same we have to look for the RR interval. It's regular. The QRS is narrow, R interval is regular means that is the problem with the atrium means paroxysmal supraventricular tachycardia. Okay, this is the ventricles, this is the atrium. Supraventricle means it's above the ventricle, means in the atrium it's a tachycardia. Okay, so that is the supraventricular tachycardia, we can say in general to understand. Okay, so that is very important, right? So but in the last one, the QRS complex was wide and PR is RR is regular. So that time we say that one is in the ventricular tachycardia. Here the QRS complex is narrow and R interval is regular. Okay, so we call this one as the PSVT, that is the paroxysmal supraventricular tachycardia. Okay, so it's important. If in case if the PR interval is irregular, so again we have to see at the more than three types of the P wave. As I told here in the normal ECG, P wave generates because of the atrial contraction. So the problem in the atrium only. So more than three type of the P wave means it's multifocal. Multi means more than one. Okay, it's more than one means more. We can say more than three. So different types of the P wave it's generating means there is a multifocal atrial tachycardia. We can say if in case the P wave is unable to identify, that is what we call the atrial fibrillation. In this entire process, the QRS complex will comes normally. Let me see the images so people will able to identify it very easily. Okay, look at this image. As I told, the QRS complex normally generates between the 2 to 3 small box. But here the QRS complex generated between the only one box. Okay, within one small box means we can say this one is in the narrow QRS complex. Okay, the QRS complex is narrow here. And then after that, what we have to see the RR interval. Look at the difference between the all RR interval. It's regular between this, The RR interval is regular. The narrow QRS complex and RR interval is regular means there is paroxysmal supraventricular tachycardia. Okay, which indicates the paroxysmal supraventricular tachycardia. This is how we have to identify the PSVT, and it's important question. Last NARSET question, this one. Okay, so it's important. So then comes to the next one, the multifocal atrial tachycardia. Okay, so we have seen that one. Yes, look at this one. First, we have to see the QRS complex. Yes, it is generating within one box only. Means it's a narrow QRS complex. Then go for the RR interval. Bacho, don't confuse here. So here it's generating between three large box. Look at this one. Within two large box. Again here within 2.5 large box. Means the RR interval here is the irregular. And look at this P wave. Look at this P wave. And look at this P wave. More than three types of the different P wave. In the first one, it's like this. In the second one, it's like this, sharp. Okay. In the third one, it's like this. So there are three different type of the P wave. So that is what we call as the multifocal atrial tachycardia. Okay. So comes to the chart and cross check once. Yes. So the QRS is narrow. Yes, it's narrow. R interval is irregular. Yes, it's irregular. And more than three types of the PO, it's there. Then we call this one as the MAT or multifocal atrial tachycardia. So then comes to the our very important next question, that is the atrial fibrillation. So in the atrial fibrillation, there is no P wave. Okay. So we are unable to identify the P wave. Anyone able to see the P wave here? Anywhere in the graph? No. So we call this one is in the atrial fibrillation. It's very important. It's an atrial fibrillation. Okay. So then comes to the next image. That is very important. Look at this one, Bacho. Yes. Look at this one. Oh, please wait. Please wait for a second, please. Some system error. Please wait. Yes. So look at these particular waves. It is looking like a teeth, right? Our tooth will be like this only, no? So this is what it is looking like a teeth. So we call this one as in the sawtooth appearance. We call this one as in the sawtooth appearance. So the sawtooth appearance of the P wave, it's classically seen in the atrial flutter. It's classically seen in the atrial flutter. Okay. बच्चों absent P wave atrial fibrillation, sawtooth P wave atrial flutter. Okay. And here the narrow QRS complex and regular RR interval. So we call that one the paroxysmal supraventricular tachycardia. Okay. So these are the very important questions that may strike in your exams. Okay. So the next question is, yes, which of the following medication is considered as the first line pharmacological treatment for the PSVT or the paroxysmal supraventricular tachycardia? Yes, what happening in the PSVT? The QRS complex is narrow and the R interval is regular. So that is what we call as the PSVT. Means it's an arrhythmia because it's an tachyarrhythmia, right? So here the heart rate is increasing. So where we want to control that one, the drug of choice for the PSVT is the, yes, almost all people have given the correct answer. Adenosine is the drug of choice for the PSVT. Okay, very important. The drug of choice for the PSVT is the adenosine, right? So here is the next question. When the heart rate increases, we have to do the vagal maneuver. Means, so we have to stimulate the vagus nerve. Vagus nerve is the 10th cranial nerve. Okay. So this vagus nerve is, if gets stimulated, means it indicates the parasympathetic nerve system. Okay. So it indicates the parasympathetic nerve system. So parasympathetic nerve system increases means the heart rate will get decreases. So in the tachycardia condition, in order to decrease the heart rate, we have to do the vagal maneuver. Okay. So we have to do the vagal maneuver. So now read the question properly. It's basic for you all. So that is this much basic we have to understand here. Then read the question. Which of the following are vagal maneuvers performed to reduce the heart rate? Just to reduce the heart rate. So what are the vagal maneuvers we have to perform? Yes. So option A, carotid sinus massage. Yes. So we have to ask the patient to turn the head to opposite side, and here will be the carotid sinuses will be there. So we have to rub here very fast. Gar, 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 gar. We have to rub here. Okay, then the carotid sinuses, where will be a baroreceptors will be there. That takes the pressure and that stimulates the vagus nerve. If vagus nerve is got stimulates, so the parasympathetic nerve system activates and heart rate decreases. So in tachycardia, in order to reduce the heart rate, we have to go for the carotid muscles sinus. Carotid sinus muscles. Yes, that is the correct. Then Valsalva maneuver. So in the Valsalva maneuver, we have to give the syringe to the patient. Okay, so we have to keep the syringe in the mouth, and we have to ask the patient to blow in the syringe very, very tightly. Okay, so as all of you know that syringe, if you are blowing inside, means syringe will not go out. Means air will not go out. Air will build here in our cavities. Okay, so air will build here again and again. It will stimulates because of vagus nerve. So very importantly, it stimulates again the vagus nerve. So if vagus nerve is stimulated, parasympathetic nervous system activates, heart rate comes to the control and decreases the heart rate. From the tachycardia to it comes to the normal. And so we will take any tongue suppressor or anything, and we will stimulate the posterior pharynx. Where stimulation of the posterior pharynx, it again induces the gag reflexes. So gag reflex we are inducing repeatedly means yes, there is again stimulation of the vagus nerve, parasympathetic nervous system, and heart rate comes to the normal. But one thing we have to make sure during the gag reflex induction, the vomiting may happens, and we have to keep the like kidney tray at the bedside, and we have to take precautions against the aspirations. Okay, so that is the important. Yes, all these three techniques we have to perform for the vagal maneuvers. So that is the correct answer is the all the above. Okay, so it's important. And in this next NARSET, this one may can ask. Okay, that is the Valsalva techniques in the what we can say Valsalva technique in the treatment of the tachycardia to reduce the heart rate is the by giving the syringe and asking the patient to push in the syringe. Okay, so that is the very important. Okay, so hope in the today's session everything is clear. So what we have discussed here is the very beautiful and very motivational and very important thing. Bacho, I have tried everything from my side to deliver the high quality content. So if this particular video is helpful for you, so please do share this video in your all college groups, because if some actually needed aspirant seen and took utilize of this one means a purpose of the teacher like me it gets solved here. Okay, if at least one student is get benefited from this video, my purpose is solved here. So I am not a perfect businessman. Okay, I am not here to do business. I am here to teach. Okay, I know only teaching. So my all publicity, everything is the responsibility of the students as a you. Okay, so please keep this video in your WhatsApp status and promote our channel also. So that helps me to reach the more students and to reach the whole India. Okay, so yes, it will be helpful for me also. Okay, I hope everyone, you people will keep this video in your WhatsApp status. Okay, so we will meet again in the next video. So please stay connected, stay tuned, and stay healthy. We'll meet again in the next session. तब तक के लिए जय हिंद, जय भारत.